We are live.
Good evening, everyone. So we are yet again back with another episode and a very important episode of DOS Postgraduate Education Program Retina module. And today we have an internationally recognized vitreoretina surgeon, especially for retinopathy of ROP, retinopathy of prematurity. And the most importantly, why DOS invited ma'am is because she is an excellent teacher, and that's why we have invited her, and she has agreed to take a lecture for us. Thank you so much for that, ma'am. And now I invite our coordinator for this program, Dr. Pranita Sahai, to introduce our speakers for today, and then we'll move on to the lecture. Pranita.
Thank you, sir. Good evening, everyone, and welcome to the 39th lecture of DOS PEP. And as you all know, today we are on the 17th class of this Retina module. And today, as sir has already highlighted, we are covering an important topic, that is pediatric retinal diseases, by an eminent speaker, Dr. Subhadra Jalali ma'am. We are thankful to Dr. Lalit Verma sir, who has helped us formulate all the classes and lectures and select all the eminent speakers for the Retina module, and to Dr. Anupam Sachdev sir, who has helped us get the ANBI collaboration that brings all the NBE associated hospitals on a common platform with our Delhi Ophthalmological Society. Our speaker for today is Dr. Subhadra Jalali ma'am. We all know that she is a consultant at LVPI Hospital since 1993, and she is the current Director of Quality and Newborn Eye Health Alliance at LVPI as well. She is one amongst the pioneering Indian women having exclusive retinal surgery practice. She has delivered over 900 plus lectures in more than 30 countries. She is a prolific writer with more than 250 publications and 80 plus awards and honors. Her crowning glory are the 350 plus fellows that she has trained in newborn eye diseases. That is a commendable thing to do. Everybody trains fellows, but to train in a specific subspecialty, that too peculiar pediatric eye disease, is something commendable. She is well known globally for her public health care of newborn babies in the Indian Twin Cities and setting up similar programs in many cities and countries. Her group has recently completed care of 1 lakh ROP babies across our country. With that, ma'am, I hand over the dais to you for your further lecture on pediatric eye diseases.
Thank you so much. I'm so honored to be here and share some of the thoughts that I have on this topic. So just let me share, and I hope that everybody can see the slides.
Yes,
Okay.
ma'am. Yes, ma'am. They're full screen visible.
Yeah. So let's get going and see what are the important things we need to know. My objective of this lecture is to learn the best practices for ROP screening and learn the pitfalls and dangers. And this will be part of the theory question for most of the PGs. There will not be any practical case there, but sometimes you may get some differential diagnosis adult who has a regressed ROP, but at least you should know the theoretical part. And this is not only important for you as doctors in appearing in exams, but also for your whole life, because in your families, in your neighborhood, there may be children, who
Anita, ma'am?
I think ma'am's signal
Ma'am
has
has-
gone.
Yes,
Yeah.
we've just got disconnected from ma'am. So let's wait for a minute.
Yes.
So, as ma'am was highlighting for all the students here, nowadays ROP screening is a very important practical aspect of practicing ophthalmology also. Because if you are posted in a district hospital or a district level city where you are the only physician ophthalmologist, then even if you haven't practiced ROP or retina, you are bound to screen for ROP. So as ma'am said, not only this is important for exam point of view, but also for practical and practice of ophthalmology is very important. At least you should know the basics of ROP screening so that you don't do any blunder. Because most of the medical legal cases today, whatever filed in field of ophthalmology, are either due to endophthalmitis or due to failing to do the ROP screening. It's a very important topic for all of you. Sunil, do you have Dr. Subhadra's number?
Sir, I've had a word with her. There was some electrical cut down. She's connecting back.
Meanwhile, for students who have logged in, see, almost we are about to complete our retina module. So, if you people want any particular topic to be repeated, or any specific thing that we have missed in this module, and you want to have a lecture on that, so please message in that group, DOS PEP group, or you can message me directly, or Dr. Pandasai. So, we'll try to incorporate that in our program.
Okay, I'm sorry, there was some electricity which went off, but no, I hope it will be okay.
Yes, ma'am, it's fine.
Okay, so I was saying that this journey, it started actually, those who are interested should read on the net, the journey of these preterm babies. It started in the, incubators which were placed in the exhibition grounds because nobody allowed these incubators in the hospital. And it was only in 1941, almost 10 years after Dr. Cooney put these babies in incubators in exhibition grounds, that the first preterm babies incubators were allowed in Boston Children's Hospital. 1941 and 1942, the first ROP blind baby came. And so the journey of these ROP babies from the incubator hospitals to blindness is very well known. And we in India have almost 30 million, children who are born every year, out of which 8 million are low birth weight. And there's a lot of neonatal death, which is now coming down because of the incubators which have been set up in every district. So the ROP problem has rapidly mushroomed to an epidemic in our country because so many children who were dying are now alive. They are being saved, which is very good, but the eye care has not come up. So we are seeing a lot of blindness in these babies. So when we talk of ROP, before that, we should also know what should be the general eye examination of a child. And this I'm telling to all of you who are listening, because I have seen doctors' children going blind. I have seen ophthalmologist children going blind. I have seen retina surgeons children going blind just because they did not have the information when is the first eye checkup to be done of a newborn baby. So recently, WHO Southeast Asian region has released the screening guidelines for newborn babies, including the ROP babies, and also the Government of India RBSK booklet, which is available on the RBSK website, that is Rashtriya Bal Swasthya Karyakram website. It tells how every newborn has to have one eye checkup done. So there are three categories of babies who have been trashed. So low risk are those who are normal birth weight babies and those who are having no other problems. That is category 1. And category 2 is those who were normal birth, normal weight, but there was some family history of eye problem, or there was some problem like birth hypoxia or a syndromic baby or septicemia or any other, severe sepsis and all. So this is the second category baby. That means normal term babies, but having some additional systemic issues. And we are, struggling with these patients because you know that in India we have a lot of congenital cataract families, retinoblastoma families, and as a retina surgeon, I can tell you that we have a lot of FEBR families where, the mother is blind and we have told her that your child can go blind. So I need to see that child within 24 hours of birth. So all these examinations in familial cases have to have a complete examination within 24 hours of birth. Then you can see this child. We have seen at 24 hours of birth, we can see the new vessels. We have lasered. On the top is the figure of the mother who's blind. So these children are not going to be blind. So whenever there's family history, we have to actually do antenatal counseling and then see them within 24 hours of birth. So for the high risk, which is the preterm babies, which is our topic today, we follow what is called the 1, 2, 3, 4 rule. So many times when we ask the PGs or the doctors who we have to ask the question, which babies to screen, they get very confused because there is different criteria in USA, UK. In your textbook, there may be different criteria. So for India, the criteria is 1, 2, 3, 4. Very easy to remember. The first eye checkup within 30 days of birth, that is 30 दिन रोशनी के. So within 30 days, you do the first eye checkup. The 2 kg, all babies less than 2 kg have to be screened, and 34 weeks. So any child less than 34 weeks has to be screened. So it's easy to remember 1, 2, 3, 4. And babies who are more than that is more than 35 or more than 2 kg, but they were in NICU because of some sickness criteria, they also have to be screened. So prematurity is called up to 37 weeks. So all babies less than 34 weeks, less than 2 kg, first eye screening within 30 days of birth. Those who are preterm but born after this, if they have sickness criteria, then they have to be screened. So 2 groups of babies. So all this, as I said, is available on this booklet called RBSK. We also have this on our screening strategies in ROP, and there are other articles you can get through them. Mainly, what are the risk factors, what is the screening process, how we can, prevent this epidemic of blindness. Once they are ROP blind, it is incurable. So ROP is a disease which we can screen and treat and prevent the blindness. But ROP blindness cannot be treated, that is permanent. So when we are examining this baby, we also have to remember that these premature babies are not only having eye problems in about 15 to 20% babies, but they can also have other problems like, visual development delay, epilepsy, they can have hearing loss, they can have dyslexia, they can have other CNS lesions which affect their field of vision or color vision. So in that whole scenario, and of course they can have cardiac problems, they can have lung problems, they can have limb problems, spasticity. So in all that scenario, we have to engage and see what is our way of evaluating the eye and the vision. So this is just a picture I have shown. Many of you know that, Kho is a game in India that we play. And the person who wins this game is the team which does quick buck passing. If we keep on blaming each other, then we cannot, win this game. So same way happens with ROP. The ROP babies are with the pediatrician, the parents are tense, then there's grandparents who need to be consulted to give the consent, and then we are in an eye hospital. So it's a big team. And unless we put all the team together and we do quick passing between each other, the baby will fall through. So this is what I have shown here. In any good ROP program, it should be the baby who's in the center, not our egos, not our logistics. The baby and its red glow is at the center of the program. And we have to build that net around this baby because there are so many people involved. So I'm showing here the ophthalmologist, optometrist, the parents, the neonatologist, the neonatal nurse, the discharge staff of the NICU, then the social worker, which means the front desk counselor, the teleconsulter, the person who is going to give the appointments. So many people are there. Maybe it is the ASHA worker who has to tell that baby to go for checkup. Then the optical and rehab. So any good ROP program or any other neonatal eye care program, we have to make tiny glasses. We have to make aphakic glasses. So that is again a challenge to make small glasses for these tiny babies. Then the rehab and low vision care, all of them would require at some point of time a rehab and low vision care. And then the anesthetists, this is the biggest challenge in our country, that babies need surgery, but there are no neonatal anesthetists who are willing to anesthetize a baby who's 2 kg or 2.5 kg, and we cannot wait for baby to gain weight. It has to be operated for stage 4A or whatever immediately, and we have to do laser immediately. So we cannot wait. So we need those trained anesthetists. And so when this whole team gets together, then we are able to take up this challenge very well. So this is just to share the data. This was a DNB thesis of one of our candidates, which was published, that why did patients come beyond day 30? When, 1998 in LV Prasad Institute, we started this program. And in 94, 95, it started in All Institute and PGI and Shankar Netralaya, much before I came on scene. But still, even after 20 years, 25 years, we are still seeing stage 5 ROP blind babies like this child who was the 10,000th baby seen in our center. You can see leukocoria. Once they get this leukocoria, they are never going to see again. They are going to be blind. So when we check the data, what we found is that the largest cause of why patients did not get screened on time was they were not asked to do so. And the next second was they were asked to do so, but either the eye doctor was not available or they did not understand the importance. So they went once and then the doctor didn't show up on that day. And then when they went second time, it was already late, or even the second time doctor was not available. So doctor was supposed to visit, but he was not in the OPD or she was not in the OPD. So this is the biggest hurdle to screening, which means that our neonatologists, we have to work with them. We have to make sure that they write this in the discharge card on what date, where, which time the baby has to be screened for ROP and where they have to go. And when they come back to the pediatrician for next checkup, the pediatrician has to ask that history. Did you go for checkup? Where is the report? What happened? What did the doctor say? And many times the doctor will say, come back for second checkup, third checkup, because we have to follow up these babies. Then did they go back? So we are requesting the government, it has not happened, but we are requesting the government so many times that just like the vaccination card, in that vaccination card only there should be a column which says, eye checkup at day 20 or day 30. So, but it is important for the people who are discharging that baby to explain the importance. So many times the doctors have mentioned ROP screen, but they have not explained. So how many people from our rural areas can actually read that, handwriting of the doctor saying ROP screen? So unless they are brochures, posters, they are brand ambassadors, they are people telling on the TV, media that there's something called ROP, preterm babies need eye checkup, it's not going to happen. And this is not only in our country, everywhere else. So this is very important that, people, when we work with some teams, that we would talk to the neonatologists and explain to them this data, that the maximum number of stage 5 come because they did not understand the importance or they were not told to go on time. So these are some of the posters that have been made with the help of Government of India. And these are freely available to any one of you. If anybody wants to have these posters, please feel free to ask, email us. They are available free of cost. We have no copyright on them. The LVPI logo is there. We have no issue if somebody puts their own sticker and their own hospital logo on that, or their state logos on this. There's absolutely no issue. And these posters are freely available for people to use. Now, so the screening guidelines are based on the 234 rule, as I said, 2 kg, 34 weeks. So this is now accepted by Government of India also, the 234 rule. So this is very nice that everybody is on the same page. Now, when we are examining these patients, most important is to be safe. Now, these children can die anytime, anywhere. And mostly they die because of hypothermia or hypoglycemia. So when they are in your OPD or you are going to the NICU, you should be sure that baby is wrapped up nicely. It is not open. So here we are showing tapas, doing the screening on the reverse kangaroo mother care. So it can be done on mother, chest, and baby is warm. It's not cold. After feeding and baby is silent, it's very comfortable on its mother's chest. So different places you can do, but we must make sure that baby is covered well, it is not cold, and baby is fed and burped about half an hour, 45 minutes before you start the screening. So the safe screening also requires that we use the hand scrub and we burp the baby, and we should use only the the dilating drops, the dilute dilating drops have to be used. No atropine and no phenylephrine. 5% or 10% phenylephrine drops. Be very gentle while examining. Do not press the supraorbital ridge, as that is very painful. We can use a pediatric speculum and a depressor, and in these cases, these are autoclaved and washed and fried, and try to examine the baby away from the attendant when you are using the speculum. If we are going to treat, then the baby must be treated only in the operating room setting or in the neonatal intensive care unit, where there is a neonatologist or a neonatal anesthesiologist who can intubate the baby in case the baby develops any breathing or cardiac problem. So the safe dilating drops are 2.5% phenylephrine and 1% tropicamide. 2 or 3 drops must be put 10 minutes apart. Always wipe the eyelids after instillation, as it can get absorbed through the nasolacrimal duct and the surrounding skin. And watch the pulse and respiration of the baby. And then you can also use the speculum, as you can see in this picture. And the screening can be done either with indirect ophthalmoscope or with video indirect ophthalmoscope or with various retinal imaging cameras, which are now available in various formats. So when to screen, I think this is the most important part of this lecture. Please still Roshni Ke 30 days to vision, day 20 and 30 strategy. All babies must be screened within 20 to 30 days of birth. The smaller the baby, the higher and earlier is the risk, and it is good to screen before handing over the baby, because the baby may leave against medical advice. So before the baby leaves the NICU, one screening should be done if you think that the baby is not going to come back. So if we look at the criteria, this everybody should know here, that what we are advocating is, if the baby is smaller and higher, lesser gestational, then they have more risk. Whereas if you look at the American Academy of Ophthalmology or American Academy of Pediatric guideline, what they write is If the smaller baby, you screen later. That means they are saying that a 22-weeker should be screened after 9 weeks, a 23-weeker should be screened after 8 weeks. Now, see, these are very difficult way to convey to our health workers. We have hundreds of children. There are only few doctors and few nurses. How are they going to even measure? Our mothers don't even know their gestational age. They don't know it is 24-weeker or 28-weeker. They will just come and say, I'm 6 months pregnant, I was 7 months pregnant, I was 2 weeks before due date. So it is very difficult to know what is the correct gestational age of this baby. And if you see this American Academic Guideline, in the bottom line, in the footnotes, they have written based on insufficient data. So, so for us, what we find is that this database or whatever guideline they had made, this was made in 2018 when we did not have APROP, we did not have anti-VEGFs, we did not have all these very, very tiny babies surviving like 24, 25 weekers, which are now surviving 300, 400, 600 gram babies. So really to make the guidelines so complicated, which cannot be used on the ground by millions of health workers, becomes very complicated. So that is why in India and in most of the developing countries, now it has been accepted that the first examination will be done before 30 days of birth. So you can measure, you can tell. Everybody knows what is the date of birth, so everybody can know what is 30 days to vision. And if it is smaller baby, then please screen a week earlier, because then you can pick up the aggressive ROP earlier and you can treat it much more efficiently than seeing it in a much later date. So then we come to, after knowing that which babies to screen and when to screen, we also should know that there are certain risk factors for ROP. So this again comes as a question in your exam. What are the risk factors? So most important to know is that prematurity itself is a standalone risk factor. Even if the baby had no other problem, but it was premature, then it has a risk of getting ROP. Now, many times, as I said, we don't know what is the gestational age of the baby. So we are using birth weight also as a surrogate measure. So birth weight can be variable, but yes, if it is less than 2 kg, then we should screen. Now, if a child is more than 2 kg, but it is preterm, and its weight is more because it is born to a diabetic mother, or it has hydrocephalus, or it has some kidney failure, or it has intestinal obstruction, then its weight will be more, but it is preterm. So that is why we should never use birth weight alone as the criteria. So it says prematurity and or birth weight low. So all premature babies have to be screened. If we don't know its exact gestational age, irrespective of the birth weight, it may be 2 kg, 2.5 kg, 3 kg, but it is preterm, then we should screen. Now we know that if the mother received antenatal steroids in the second trimester, these steroids injectable, betamethasone or dexamethasone, are part of our National Janani Suraksha Yojana. All the mothers are expected to receive these steroids for the lung maturity, for taking care of the bronchopulmonary dysplasia. So they protect against the lung problem, but they also protect against ROP. So those mothers who have received steroids have some protection to them, to their baby. Now, those mothers who had anemia or had poor weight gain, their babies are more at risk. And those babies who received fluctuating oxygen or unblended oxygen, which is very common in our rural areas where they don't have blenders because they're expensive or they're not readily available, then they are more at risk. But always remember that babies who never received oxygen can also get very severe ROP. So prematurity itself is the highest risk factor, and these are the other risk factors. So now the other risk factors are, of course, how the patient was taken care of during the delivery. So what is said is that there should be something called in utero transfer. That means if we know that somebody is going to deliver a preterm baby, then it is better to deliver that baby in a place where a good neonatologist is available. So if we know that mother is, high risk of premature delivery, or they have twins or triplets, or she has premature rupture of membrane, then try to transfer and deliver in a center where good care is available. Now, this is not always possible. In our rural areas, this may not at all be possible, but this is what would be the ideal way. So the first golden hour after delivery is most important for ROP prevention. Delayed cord clamping. If you wait for some time and squeeze the blood from the cord into the body, it helps the baby not to get anemia. It helps the baby to get less ROP. Then immediately after delivery, baby should be placed on the mother's body, so that there's a skin to skin contact, and the baby starts getting good thermal regulation, and they are not cold, so they are not delivered and kept on the side on some table where there is no heat. Then breastfeeding as soon as possible. The patient is, encouraged to feed their baby, because this helps in hypoglycemia prevention and it also helps in sepsis control. Now, the oxygen management in the labor room is also very critical. Most of these babies initially for first 5 to 7 minutes will have oxygen saturation of 70, 72, 75. So we should not give them oxygen at that time. That also unblended oxygen. So there are guidelines. These are called NRP guidelines. And that should be followed of when to resuscitate, when to give oxygen. So every baby who is born, we should not just push that oxygen into their nose just to be sure that baby doesn't go into cyanosis or hypoxia. So there are certain guidelines which have to be followed. So we are not, experts in that, but we should tell our teams of our neonatologists that please follow the NRP guidelines. So this I have prepared. This is called Six Sigma checklist of care. As ophthalmologist, we should check, correct, and monitor along with the neonatologist and the family. Whenever babies come to us with some ROP and we are going to follow, we say like, this ROP doesn't need treatment, it is mild. We don't want it to become severe. So how can we prevent it from becoming severe? Or if we get severe ROP and we are giving an injection or giving a laser, if we just treat the eye, it will not regress. Many times I get phone calls or messages from fellows or doctors from other parts of the country that I have done laser, baby is not responding. I have given injection, it has come back. It is because we did not take care of the systemic factors. So these are the systemic factors which worsen the ROP: poor weight gain, poor oxygenation policy, any infection in the lungs or in the respiratory system, nose block, abnormal lung issues, cough, cold, they will have an effect on ROP. Anemia is the biggest risk factor. I will show some data. Then sepsis, if the child gets pneumonia, child gets sepsis anywhere in the body, it leads to a lot of inflammation and the ROP worsens. We have shown that in our data by taking vitreous of patients who came with detachment, and it is showing a lot of inflammatory cells. So there's an upregulation of inflammatory responses if the baby has inflammation anywhere in the body. And also the mental health of the caregivers. I will come to that soon. So let us look at weight gain. So there is good data to say that if the baby has slow weight gain or prolonged weight loss, then they get more severe ROP. And there are studies which show that, low serum insulin-like growth factor is a risk factor. And people have shown that you can actually use this IGF levels to predict whether they are going to get ROP or not. But the problem with this IGF level and that study is that they pull the data and then tell it later. So that is not going to help us. But later people showed that just the weight gain itself, and that was in 2009, very nice publication. So this is called Windrop study, where they showed that weight gain itself is a good marker. So we are using it in our hospital and it's very good. So if the baby is very thin, tiny, it is not gaining weight, so weight gain should be at least 100 gram increase of the weight, it will reduce your ROP by more than 27%. So when you're monitoring these babies, every time they're coming to you for follow-up, either after injection or laser, or even you're just following up, ask what is the weight gain. So at least 25 to 30 grams of daily weight gain is what we call as a good weight gain. So if the weight is not increasing, then you talk to the neonatologist or write a note to the neonatologist that, the baby is not gaining weight, so it is not going to improve its ROP. So please help us to improve the weight gain. So there are various, supplements they give and the various things they do to improve the quality of the breast milk and also to add supplements to the breast milk so that the weight gain is more. So oxygen, of course, this is a big topic. I'm not going to all the details, but we all know that oxygen does not cause ROP. As I said, that ROP happens because of prematurity. But poor oxygenation policy worsens the ROP. We know that, oxygen is toxic. It's a drug. It is very toxic to the growing vessels. So there is, a lot of debate on what should be the good saturation. So currently the consensus is that the SpO2 levels, when we put the oximeter and the patient is on oxygen, it should not be more than 88 to 93%. So it should not be 95, 100% on your pulse oximeter. And more than the absolute number is the fluctuation. So what these nurses do sometimes is when they are feeding the baby, they give them oxygen because patient is desaturating. Then they stop it because they're scared that now child will get ROP. This is the worst practice to do, because these are the babies who are going to get very severe ROP. So it's better to give oxygen blended in a low dose and monitor that oxygen. Now, monitoring that oxygen and giving that oxygen as per the NRP policy requires nursing. requires a lot of nurses. But you see, if you go to our government NICUs, there'll be 200 babies, 300 babies, 4 or 5 babies on one bed. We don't have those nurses who are going to monitor every baby. But what we do is that when we do the screening, if we find a baby has ROP or zone 1 retina, we say at least monitor this particular baby. At least keep one nurse available for this particular baby. So other babies, okay, it is going to be difficult. But you see, that is why the ROP is less in high-end nurseries, because there is one nurse for one child or one nurse for 2 children. Whereas from the other nurseries where there are not so many nurses, we get so much of ROP. But still, while it will take us time to get enough nurses and enough blenders and all, if we can at least screen them on time, then at least we can treat them on time. But our ultimate aim should be reduce the severity of ROP and reduce the prevalence of ROP. So for that, we need to take care of these practices. Then we come to anemia. So previously, currently the anemia control policy, there is a transfusion policy which they use, but they are not using ROP as a criteria in that policy. So now we are trying to say that, ROP should also be given importance in that policy. So if child has ROP, what should be the policy of giving transfusion? Currently, the problem is that if you give blood from outside, then this is a adult hemoglobin. There's something called fetal hemoglobin. So fetal hemoglobin oxygen dissociation curve is different from the adult hemoglobin. So when you have fetal hemoglobin in the baby, even if baby is receiving oxygen, the oxygen doesn't dissociate from the RBC, so baby doesn't get toxicity in the tissues. But when you transfuse adult blood in these babies, then more of oxygen per unit of that blood is going into the baby's body, so they are getting more toxicity. So there is a problem. The other problem is if you transfuse too many times, then the patient's own blood forming capacity gets suppressed. Okay, so their spleen, their bone marrow, that gets suppressed because now it is already getting preformed RBCs. So to prevent this, there are guidelines by the neonatology forum of when to transfuse and not to transfuse. But as I said, that they are not considering the ROP. So what we found in our studies is that if there is ROP and baby is anemic, suffering from moderate or severe anemia, then the ROP doesn't regress. So we are saying that, when there is ROP, that should also be a criteria for them to decide to give transfusion or not to give transfusion. So other thing is the infection control and sepsis policy. As I said, if the child has sepsis, there's upregulation of all the inflammatory markers in the body, and the ROP also worsens. So hand washing, barrier nursing, not load the babies with a lot of antibiotics. That actually causes a lot of toxicity. But prevention of infection is more important. There's something called bundle care, which means handle the baby only minimal times. Don't keep on, going there for feeding once, diaper once, injection once, taking sample once, then showing to the parents once. No, the baby should be allowed to rest and sleep. And there should be only bundle care, which means everything that has to be done to the baby has to be done at one time and then stop it. Don't every half an hour go and do something with that baby. So coming to the lung immaturity, what we found and other data has also shown that the lungs being immature, they can cause apnea, and that has a very direct bearing on the hypoxia of the retina. So whenever there is a chronic lung disease, you are examining the baby is having a nasal discharge or baby is grunting or not, having clear sounds, then you know that this patient has a lung problem and its ROP is going to worsen. So they need to take care of that. So there are various things which are written here to do chest physiotherapy, to keep the nasal passages clear, to give nebulization. And if there is an pneumonia, then to give parenteral antibiotics. So these can be silent disease. The lung disease can be silent. Whenever there is lung problem, there will be slow feeding, there will be grunts, lethargy, SpO2 will be fluctuating. They will not feed, they will not gain weight. So all this will affect our ROP status. So this is what I was saying. There are some NRP guidelines how to resuscitate. So we don't need to know this. We should only know that there is a guideline which tells at what minute after birth the oxygen has to be given and what is normal. What is normal SpO2 after birth and after how many minutes they have to give the oxygen. So anemia, as I said, so we showed that moderate to severe anemia, which is described as any hemoglobin less than 10 gram%, is what will worsen the ROP. So again, this is to be discussed with the neonatologist, and if it is low, then we should give. So there's a lot of literature on anemia and ROP, both from our center and from other places. And this is just to show the objective. Recently, we have published this, that when we are looking at the ROP, we can do the OCT, and OCT is showing that there is cystic changes in the retina, there is thinning of choroid, there is, increased hyperreflectivity. So if there is complete good retina, that is, there are some cystic changes, there is no hyperreflectivity and choroid is thick, then they do very well with anti-VEGF and there's no recurrence. But if they have this destruction of the inner retina, there are PAM lesions, that is, there is no cyst changes and there's hyperreflectivity with choroidal thinning, then these are the eyes, in spite of anti-VEGF, they will come back with recurrence or they will not respond. So this is some new information. There's new literature. This is advanced. This can come as a question in your recent advances. What are the recent advances in ROP care? So the OCT examination of these babies, fluorescein angiography, these are coming up now, and people are looking at the choroidal changes. People are looking at the ischemic changes on OCT. Even the new classification is saying that ROP stage 2, stage 3, we can do by wide field OCT. So in future, these things will come more and more as we get more handheld OCTs available for children. So just like OCT has revolutionized the way we treat diabetic patients or CRBO patients, it is going to revolutionize how we understand and treat these ROP babies. So anemia is a risk factor, and here I'm showing that there's something called crunch phenomenon. When we give anti-VEGF, sometimes the whole retina can just detach and form membranes. So we have found that anemia is a risk factor for this crunch phenomenon also. So this is just to say the data which has just been published, that those patients who had anemia and they received transfusion, they did much better than if they were not given transfusion because of some hesitation on part of the neonatologist or the parents not willing for transfusion. Then they had more chances of getting reactivated. So I'm just going to go through that. The last point I wanted to say was the mental health of the caregivers. It affects the ROP, because if the mothers are stressed, then they don't get enough milk to breastfeed the child. So obviously patient is then at risk of poor weight gain and sepsis. If they have higher anxiety or there's depression, and when they are having this preterm baby, there's a lot of stress to the family. A lot of parents divorce or they start living separately. There's a lot of blame game given by this vulnerable child or blind child or handicapped child or child with so many problems, heart, lungs, spasticity coming to my family. Then it all affects the compliance. So if there is a broken family or they are fighting with each other or they're not having enough resources, then there's poor compliance to ROP follow-up. So ROP care is not just one visit, it requires multiple visits, and the whole family has to be together during that time of challenging time and crisis time. So whenever we as ROP specialists are talking to the parents and we realize that there is some stress going on or they're not on the same page, then we take time out, we counsel the families, we talk to the mothers, we give them a lot of assurance that your baby is going to be fine. Just talk to the baby, we are there, we are going to treat it, you have come on time, and treatment is available. So you just keep on concentrating. If you like your baby, if you really love your baby, you want to care for your baby, stop crying, stop worrying. What you need to do is give it the feeding, give it the warmth, give it the care, and bring it for follow-up, and then together we can do good to the baby. So that type of counseling and keeping the mothers and the parents together during this ROP journey is very, very critical. So here you can see, this lady, her baby is so tiny, and she handed this baby over to me for surgery. Baby was just 900 grams on the day of surgery, and she's just giving that baby to me and saying, "Madam, aapke haath mein hai, aap iska care karo." So if they are worried, they are scared of the surgery, they are worried about the anesthesia. You can see here Dr. Komal. So our ROP care just doesn't stop at putting some drop, putting a speculum, looking at the retina, treating that. No, it is a very holistic care. This is Dr. Biju Raju giving kangaroo father care to his own baby who had ROP, and he has given permission to use this photo just to motivate all of you that we don't have to be scared. Even if in our home or we as doctors, we have a premature baby, they can do very well if we screen them on time and take care of all the things. Then 80 to 90% of these babies see very well and they do well. So to recapitulate the risk factors and how to manage the maternal health and weight gain, antenatal steroids, best practices during delivery, the first golden hour, asepsis and bundle care, expressed breast milk and postnatal weight gain, oxygen management, lung therapy, anemia, judicious medication, and mental health of the caregivers, and then timely screening for ROP. Now, sometimes people get very confused how to detect ROP. The most important thing is to know what is normal. A normal newborn retina has just few vessels You can see here in the first picture, I hope you can see my arrow, that there are just few vessels and the retina is completely clear. Whenever ROP occurs, two things happen. The pupil dilates slowly, it never dilates fully, and you will see this posterior pole just near the disc, little tortuosity of the vessel. So these are signs of early ROP. All ROP eyes, when they have ROP, they will dilate poorly. The pupil will not dilate fully. Media will sometimes be not clear. But the first sign is seen at the posterior pole. There will be dilatation and tortuosity of the vessel. Of course, if there is prominent dilatation and tortuosity, you can compare it to normal. Then you know that there is significant ROP, which we call plus, and that eye needs treatment. And then when you start going towards the periphery, you will see that the vessels just stop. They are dividing, but they are not moving forward. Normal vessels here, you can see, they are dichotomously branching and moving forward. So that is normal. So normal vessels should dichotomously branch and move forward. But if they dichotomously branch and they're not moving forward, then we call this staged ROP. So you can have stage 1, 2, 3, whatever. But the other type is if the vessels are branching, but they are not dichotomously branching. They are not one is into two. They are forming loops. Now this is very severe ROP. So we should not miss this stage. This is the stage which many times people miss because they don't look at the pattern. So we have to look at the pattern and the extent of vessels. Only two things you have to see. And here you can see the vessels have dilated and now they're coming into the vitreous cavity and there's avascular retina and vascular retina. So these are all showing the different stages of ROP and how the ROP looks like. Okay, so here you can see normal eye where there's dichotomously branching, completely clear retina, and here you see abnormal pattern of retina. So this is what is now called aggressive ROP. Previously it was called aggressive posterior ROP. All of you must read and be fully aware of the ICROP 3 classification, that is international classification for ROP. 3, that is recent advances. So there was 1, then 2, and this is the third one. So everybody should know what is the recent classification. I'm not going into that now, but that is part of your theory question to know the zones, the stages, how the ICROP 3 has come up, and the new terminology is AROP, aggressive ROP, which is characterized by this looped vessels in the posterior area of the eye. So I'm just showing this here that somebody has...
can often be missed or misinterpreted. You can see in this picture a beautiful diagram which is showing the retinal hemorrhages and there are looped vessels, and then somebody has written that there is no ROP and we need to wait. This patient will have detachment. So it's very important that when we see this abnormal pattern of vessels, we recognize it as a serious AP-ROP and require immediate treatment within 1 or 2 days.
So I have shown that in that photo before. So now to summarize, as I said, the most important thing for our country is that babies are getting missed. So that we don't miss them, we should have fixed 1 day at time of a week, which should be clearly mentioned. So there's be good dialogue between the ophthalmologist, what time you're going to go there to NICU, what time you're going to screen. And there should be one person in the NICU who will maintain a diary or a register, which babies are to be screened, which babies came, which babies did not come. So nowadays it's very good. When I started in 1998, it was very difficult to trace those who did not come. But now with the cell phone revolution, all the patients have a mobile. So, we are capturing that mobile number, and if they didn't come, we can always message them or, WhatsApp to them and say that, hey, you missed it, please come because this is serious. So like that, we can now track and trace all these babies who never had an address or no contact, but now we are able to maintain that. Now, when we do the MOU with these hospitals, we clearly mention that the onus of getting the baby to us is by the neonatologist, and it is their liability and their social, moral, whatever health, responsibility to see that baby is brought to us. Because when we go to that hospital, we don't know where the baby is. Baby may have been in some special room, or he may have gone for X-ray or ultrasound or whatever. So they have to maintain the diary, and they have to ensure that all babies are screened, and all the staff should know that this is an emergency. So our ophthalmology staff and the neonatology staff, they should know that, this is emergency, it cannot wait, we have to see them. And if we are going on leave, somebody else is there to take care of these babies. So we should not just leave them just like that and not be available, because if you are not available once, they won't think that this is serious, and then they will miss that opportunity. So here I'm showing this baby belongs to a pediatrician, that we don't have to be scared of the disease. Once we treat, the retina comes back to complete normality. The laser marks move to the side. We don't have to worry too much about the field loss in zone 2 or 3. So the field loss happens in zone 1 disease, but nowadays we are treating that with anti-VEGF. We are not treating that with laser. So we are really getting very good outcomes, 20/40, 20/30 or better vision in almost all the babies if they came to us on time and we were able to screen them on time. So the reward, of course, it is vision which will last for a long time. These are triplets we treated just on the brink of blindness. This father, he was not told that your triplets need ROP screening, but he has a video there where he says that I was searching on the net what are the problems which can happen in preterm babies, and then he saw the video which said that ROP screening is required, and he came, and 2 babies needed detachment surgery immediately, stage 4A, and 1 baby we treated with anti-VEGF, and today all 3 are having really good vision. So that's the importance, that's the reward, that you are preventing blindness. You are really giving a lot of sight to these children who will otherwise become blind. So I am happy to take any questions. We still have 15 minutes.
Thank you so much, sir. Thank you so much, ma'am, for giving us a really nice insight on this very important topic. We all get theory covered in a lot of classes of ROP, but the important aspects as to what to look into and how to evaluate these kids is something you've really added on, and I'm sure the residents are going to learn a lot from these. There are a few questions that we have. Praful sir, are you there? So in the meantime, we'll take some
Yes,
questions.
please go ahead with the
So ma'am,
questions.
one of the resident has yes, yes. Sir. So one of the resident has asked as what should I do if the pupil is not dilating and child is referred for screening?
So if the pupil is not dilating, and the way to dilate is put, Paracane drop, and then put the dilating drop every 5 minutes 3 times. That is the first step. How to prevent this problem from happening? The problem happens because we just go and put 1 drop, and then for 1 hour we forget. And then after 1 hour, we remember to put second drop. No, put 2 or 3 times drops every 5 minutes along with Paracane, and of course clean the eyelids. So that way you can be sure that it will dilate. Now, if after this it has not dilated, that means it has very severe ROP behind. Okay, look at the pupil nicely with your 20D as a magnifier. You will see NBI on the pupil. Then you know that this child needs an injection. If you use the small pupil diameter viewing from your indirect, you can usually see that there is some dilatation and tortuosity behind. That's all you need to know today. Okay, then you can go ahead and inject. After injection, within 2 days, 3 days, it will dilate. In the era when we didn't have injections, what we were doing is we were going ahead and trying to laser. The moment you start the laser, the pupil starts dilating. You cannot do complete laser in the eye, but 90% laser we were able to finish. So when we start lasering, then with the pressure of the depressor, when you put 8, 10, 20 spots, the pupil somehow dilates. It dilates on its own because of the irritation. So this is some things you can do. So don't keep on putting drops to dilate. Don't say that I could not dilate, so I could not examine. Okay, because if it is normally in 100% of children, the moment you put the drops, within 15, 20 minutes, the pupil dilates. It dilates very well and fully with this drug and this approach. If it is not dilating, that means there is severe ROP behind, and you need to intervene either with laser or with injection. Suppose the baby has come late to you. Suppose it didn't come within 20 to 30 days, but it came at 1.5 months or 2 months and all. At that time, you can do an ultrasound to make sure that there's no detachment. Because if there's a detachment and you try to inject, you may injure the retina. It may be just behind the lens. Then you need to send it to an expert where they will inject properly under the microscope, and they will do the surgery also after making sure that baby is GA fit. But other than that, if patient has come to you on time within 20, 30, 40 days, the detachment doesn't happen so early. So you are safe in injecting if you can, document that there is some NBI, pupil is not dilating. And even just NBI, then you can put the injection. Okay, now sometimes very rarely in little bigger babies, you can have something which looks like NBI, but it is not NBI. It is like a syncytium of vessels, which is actually the tunicosa vasculosa lentis. So we need to differentiate tunicosa vascular lentis from NBI. So there are good pictures on the net in the books. You can look at that. I don't have a picture of that now, but the tunicosa vascular lentis is usually very curvilinear. It is all around the pupil, and it is raised from the surface. It is raised from the surface of the iris. It is not within the iris, and that will disappear within few weeks. Even tunicosavascular lentis eyes, the pupil dilates. It's not like pinpoint pupil. It doesn't dilate fully, but it will dilate decently. Okay, and through that, that syncytium of TVL, you can see that behind the vessels are normal at the posterior pole. And when you see them after a week, the tunicovascular lentis usually has disappeared and you can do good screening. Okay, so you need to differentiate that. But suppose by mistake, now you're in some area, you're not able to get all the information. By mistake, you have injected an eye with tunicosavascular lentis and not ROP, it's fine. Okay, we should try to differentiate the two. But if you have injected, at least you will learn that this was tunicosavascular lentis and there was no ROP behind. But learn how to differentiate NVI from tunicosavascular lentis. A purely non-dilating pupil because of NVI and sphere ROP behind from a tunicosavascular lentis. Okay, so clues are there, pictures you can see on the net, and you can differentiate between the two. And whenever you are in doubt, I think in today's era and date, with everybody having smartphones, everybody should look at the publications by Dr. Mahesh Shanmugam. Other publications are there on the net. Also, a lot of data is there to how to use a smartphone to take a picture of the retina of a baby. It's very simple. With 20D diopter lens, your own cell phone, you can easily take a picture. So whenever you are in doubt, you can take a picture and share it. You can share it with experts. You can, put it there that I am having this type of retina or I'm having this type of eye. This is the weight and age of the baby. What do I do? So people are there to help you. If you are in a place where you're new, you still have less experience. Yes, it can be done.
Ma'am, the same resident has another question. Which dilating drops are ideal for use in these patients, in these small babies, for achieving good dilation?
So there are
And
two
also
drops
safe.
which the National Neurology Forum and the RBSK India guidelines, two drops we have recommended. One is 1% tropicamide with 2.5% phenylephrine. Okay, so this is one drop. It is available as ready-made also. If you don't find the ready-made one, it is available as, I think, Tropica Semi P with P. So it says, pediatric, that is available. So that you don't have to dilate, it is ready-made available. But suppose you are in some place where you don't have that, then you take the normal 5% phenylephrine tropicamide solution and you dilute it 1/2. Okay, and then but that you have to discard after you use, then next time you have to prepare fresh. So you can prepare it in a syringe and dilute it not with distilled water, but dilute it with any lubricant. Now, if you dilute it with distilled water, then its pH and all changes. So you can mix it with any lubricant like Orosol or Tear Plus or whatever. One of the lubricant, you can take 1 ml and 1 ml of this drug, and so it will become 1 in 2. Okay. The other drop which is recommended is 0.5% cyclopentolate. Now, 0.5% cyclopentolate, there's no problem. The only thing is that it takes little longer to start its effect, but the effect will last longer. Okay, so if you are going to multiple ICUs and you tell the sisters, put the drops in the morning because you don't know what time you will reach there, okay, then it will last for 2-3 hours. Whereas this drug, which I told first, the 2.5%, it will last for about 1 hour, 45 minutes to 1 hour. After that, its effect will start going. So if you are there along with the babies, by the time you take the history, you note down everything, the pupil dilates. So it's not too much time. It acts very fast. Within 15 minutes, it will start acting. The other thing with 0.5 cyclopentolate is that usually it should not be used for children who have had seizures. Okay, so we know that neonatal seizures can happen in some of these children. So if they had a seizure, then preferably we don't like to use cyclopentolate because it can precipitate a seizure. So there we have to use, then you can use plain tropicamide. Suppose you don't have 2.5% phenylephrine, then plain tropicamide also works, but it takes little longer. So the easiest, fastest, best is 2.5% phenylephrine with tropicamide. But the side effect can be there. They can get, hypertension. They can get, hyperthermia. They can get tachycardia. But it has been found that if you use it only 2 times, okay, and just use it the way it has been recommended, then there is no toxicity.
Okay. Ma'am, there's another question by one of the resident. Which lens should we use for screening? What are the advantages and disadvantages of 20D over 28D?
Okay. So the first thing is 20D. So most of the people are very, tuned to using 20D in the adults. So they know how a 20D retina looks like and they're very comfortable. So for ROP screening, it is recommended you use 28D. The advantage of 28D is that you can see most of the retina right up to the periphery, but it minifies the image and its working distance is different. So it takes little time for people who have never used a 28D to start seeing the things with 28D because it will minify the images. So each vessel will look smaller, thinner than what you are used with 20D. So what the ROP Society, the ACROP classification recommended is that you start with 20D so that you can see the plus component nicely, especially when the child is on oxygen or child is anemic, because oxygen and anemia can mask the plus findings, the dilatation and tortuosity. But it doesn't mask the tortuosity, but it affects the dilatation. If baby is on oxygen, the vessels will be constricted, so you will not see the dilatation. Okay, so if you use 20D, then you get the maximum magnification. So for the posterior pole to pick up plus and to know which zone you are in, zone 1, that you use with 20D. For you to see the periphery, to say whether retina is completely vascularized or not completely vascularized, you use the 28 or 30D. Then the need for depression becomes less. So, it's said that, a bad workman quarrels with these tools. If you're a good person, you can use either. But you should know what is the view that you are getting with the 28D, what you have to see with 28D, you should know what you have to see with 20D. 20D, very good for picking up plus, not picking plus, and for seeing the posterior pole area. 28, it is very good. If you practice 28D, then what you are seeing with 20D, you can see with 28D also. But what you are seeing with 20D, you cannot. So what you are seeing with 28D, you cannot see with 20D without depressing. Okay, so to see more field of view, you have to depress if you are using 20D. If you are using 28D, then you don't have to depress. But things will be minified. Now, especially in the era of anti-VEGFs, even with 20D, the vascular pattern is very difficult to trace because once you give anti-VEGF, these vessels become very thin. And to trace them, because you have to see them week after week, 2 weeks, 3 weeks, for you to pick up that recurrence of the disease, it becomes difficult with 28D. So you need a 20D to pick up because the vessels become permanently very thin and narrow. Okay, so what I do is I use both. I use 28D and I use 20D, and I have learned what I can see with 20D, what I can see with 28D. So then depending on what finding I want to see, then I can use it. So suppose I have a child who is 35 week or 34 week or 2.2 kg. It's just borderline preterm. It has come from a good nursery. The chance that this baby will have ROP is very little. Right. So that baby, I just see with 28D. If I can see the periphery, it's normal. I can just release. I can say there's no ROP, posterior pole is good, periphery is good. Because the pre-test probability of this child having ROP was very little. Even if it has ROP, it will be very mild in the zone 2. Okay, but if it is a very tiny baby, I know this baby didn't have gain weight, I know there's a very high risk of ROP, then I will like to use 20D first, know exactly whether it is zone 1 or zone 2 disease, what is the extent, what is the pattern. If it is a post-injection eye, I will always use 20D first to know exactly what is happening to those vessels, and then I might not use 28D in those eyes because it will further minify my ability to see the periphery. So use both, learn how to use both, and then you will be the master of that skill.
Thank you so much, ma'am. We also have Dr. Anita, ma'am, who is a consultant at Gangaram Eye Hospital, and she has our NBI. She has helped us in the NBI collaboration. Ma'am, do you have any questions?
Good evening, ma'am. Thank you for the wonderful talk. Ma'am has covered everything. I was thinking of asking something, but everything has been covered in the topic. So I don't have any questions. Praful sir, maybe you want to say something?
Thank you so much, ma'am. I think most of the students they consider ROP as a topic for exam only. But after your talk today, they would realize this is a bigger issue. Socially, society, government, doctors, physician, everybody has to be a part of this ROP management. Then only we can succeed. And this is really very sad when you see ROP baby. You also feel very sad. The small babies and having all these issues, and they have to go through laser screening. So it's a difficult situation for family as well as the physician. So I hope this lecture will help to sensitize our students that this is a big problem and you have to be careful about that. And this is a small appreciation from Delhi Ophthalmology Society, ma'am. and we are doing our annual conference between 13 to 15 June at Bharat Mandapam, the venue of G20 Summit. If you will join us, then we can give you this frame certificate. And I'll request you to please join us, and we can have a session on ROP, specialized, especially focusing on the social aspect of ROP. And with this, thank you so much, ma'am, and thank you all the students. Thank you, Sunil and Pranita. We can conclude here.
Yes, sir. Thank you, sir. Thank you, ma'am. Thank you, Subhadra, ma'am, and for your time and efforts to sensitize our students, ma'am, on this important topic. With that,
Thank
we
you so
conclude.
much. Can we get the information? How many people joined and all? Just send that to me. It will be nice.
Ma'am,
Yes, ma'am. We'll WhatsApp
yes,
it
we'll
to you.
message you.
Okay, okay. Thank you so much.
Thank you, ma'am.
Bye bye.
Good night.
Thank you, ma'am. Good night, ma'am.
Good night.